Hey, good morning, everyone. We are going to start this webinar at noon, so just hold on tight and we'll get started very soon. Hi, good morning, everybody. We will be getting started in about 5 minutes. I see a couple of questions about when this is starting, and so I just want to make sure everybody knows that we're starting at noon. Good morning, everyone. I'm Jerry Katz. I'm M&A staff. We're going to get started with this webinar. Just want to welcome everyone who's here. I think we'll probably have a few more folks joining us, but I'm really glad to see lots of folks already in the chat box, in the attendance box. I'm really excited to be able to introduce all of you to Jane Thomason, who is the industrial hygienist for National Nurses United. We are so lucky to have her here. She's been with NNU for about 5 years, and she is our national expert on nurses' health and safety issues. So she has a really great presentation for us today. I just want to note that if you would like to ask a question, Jane is going to address questions at the end of the presentation, but you can at any time go to the control panel that's should be on the right side of your screen, and there should be an option for questions. So you can put your questions in there. Jane will see those, and she's going to address them at the end. So with that, I'm going to turn it over to Jane. Thank you, Jane.
Thanks, Jerry. It's really great to be with you all. I'm excited to have this time with you. Like Jerry said, I'm an industrial hygienist. Just a quick intro, if you've never heard of industrial hygiene before, that's perfectly understandable. Industrial is another word for workplace, and hygiene another word for health. My background and training, my degree is in workplace health and safety, thinking about how workers may be exposed to hazards, to injury or illness at work, and what employers need to do to make sure that workers don't get injured or sick because of their job. And because I work for NNU, my role is to work with you all, to work with nurses, to think about what we can do together to get your employers to provide you the safe workplaces that you deserve. And so we're talking today about reopening specifically in the context of this COVID-19 pandemic. So we can go ahead and jump in. There are some slides to view for those of you who are logged in. So we're seeing this rush to reopen as soon as possible, right? The dedication of our policymakers on the state and federal levels is very, very clear. The dedication to the economy is very, very clear in this situation. The map on the slide is from the New York Times and has color-coded the states that are either fully reopened or well on their way to reopening. Some regions, some counties may be reopened, such as in California or Oregon, and others may still have stay-at-home orders. And the vast majority of states are fully reopened at this point. And yet cases are still rising in the United States. The numbers from yesterday are here on the left of the slide. We have increasing cases and increasing deaths still in the United States. So I want, before we jump into some of the specifics on reopening, to take just a second to take a little perspective together. So I know for each of us, likely each week of this pandemic has felt like a month, really. And I want to just review, all of this started in late December when a cluster of pneumonia cases were identified in China. And the source of those pneumonia cases wasn't actually found until January 7th, when this virus, this coronavirus, SARS-CoV-2 that causes COVID-19 was identified. And that was a mere 161 days ago. Which really is not that long ago when we're talking about a brand new virus that we're studying. So here's a quick agenda for our presentation today. We're going to go through some recent updates about COVID, just the highlights, what we know about the virus, how it impacts people, how it's transmitted, and what this information means in the context of reopening. And then we're going to talk a little bit more about reopening specifically, some of the rhetoric and some of the trends that we've been seeing, and what the impacts are likely to be. And then we'll finish up with a brief discussion about what needs to be in place for reopening to happen more safely. And I want to be clear at the outset of this conversation with you all that while this virus is still circulating and while there's no vaccine, there's technically no way to reopen safely, but there are ways to reopen more safely. There are safer ways to reopen. And those are some of the things that we'll talk about at the end of our time together. And then we'll have some time for Q&A at the very end. Okay, so let's go ahead and jump in. What have we learned about this virus in the few months that it has been identified and studied? So one of the things we've learned about this virus is that symptoms are wide-ranging. And it seems like every couple of weeks there are new symptoms that are reported. And you can see the list on the slide from a report from the CDC. But the top three, the cough, fever and chills, and shortness of breath, are the most commonly focused on symptoms for SARS-CoV-2, for COVID-19. And we've seen many hospital protocols that are focusing exclusively on these top three symptoms. And what that means is that they're going to be missing patients that have SARS-2 infections, but don't necessarily have these three specific symptoms, right? Some patients sometimes show up with just GI symptoms. Some patients just show up with chest pain. And if the hospital is focused exclusively on cough, fever, chills, and shortness of breath, they're not going to identify all patients that have this virus coming into the facility. And that's of particular concern in our conversation about reopening when we're thinking about hospitals that are rushing to reopen these procedural and outpatient areas. As these elective procedures are being resumed, there's going to be more patients coming through the facility, which means there's more potential for the virus to be introduced to the facility, and then there's more potential for the virus to spread within the facility. And if the hospitals are using only these limited screening criteria, then they're going to miss cases, and then there may be further transmission within the hospitals. And there's one more piece that I want to talk about when we're thinking about the implications of this information for reopening. And that's that we're seeing a lot of employers, as they're talking about what their plans are for reopening, focus exclusively on fever and symptom screening and the workplaces as like the major thing they're doing to safely reopen. We know that just screening for fever or just screening for a few like cough or shortness of breath is not going to catch all of the cases. And so it's concerning that there are some employers that are relying on fever and symptom screening to make their workplaces safe as they reopen. On top of that, right, there's this whole category of this whole issue of asymptomatic infections. And symptom screening won't catch these asymptomatic infections. We've learned over the past few months that a significant proportion of SARS-2 infections are asymptomatic. Some people don't even know that they've been sick. And this is potentially in the range of about 50%. There are several studies listed on the slide that have measured these numbers, right? About 50% of patients are asymptomatic at the time they test positive by PCR test. And there's other studies that have shown that asymptomatic transmission appears to be very important to how quickly and widely this virus spreads. Potentially even half of the new infections may be spread during asymptomatic or pre-symptomatic infections. So this has really important implications when we're talking about reopening. There's also been reports of physiological impacts for asymptomatic cases. We might think, if you're not super sick, then you're not super sick and there won't be significant impacts. But what we're actually seeing is that there are physiological impacts reported. The CT scans, lung CT scans that you see on the slide are from a report, and these are from asymptomatic patients. And this report reported that a majority of the asymptomatic patients that they studied had these characteristic ground glass opacities that are common or that are characteristic to SARS-2 pneumonia. And that can come with long-term damage to the lung tissue. Another thing that we've learned that's important to consider when we're talking about reopening is that early on in the pandemic, there was all of this talk about how people with comorbidities and older adults were more susceptible or more vulnerable to a severe COVID infection. And while this is true, right, chronic diseases can leave organ systems more vulnerable to the impacts of SARS-2. I want you to look at this data from the United States with me. So on the right-hand part of the slide in the table, that is data about these comorbidities. And in the United States, 1 in 4 patients with a severe COVID infection who had to be hospitalized had no chronic disease or comorbidity reported. So 1 in 4 patients that develop a severe infection don't actually have a comorbidity. And then the graph on the left is the age distribution of cases who were hospitalized. And there are certainly a lot of older adults, right, looking at the 60 to 69 and above age ranges. There are a lot of older adults who were hospitalized, but there's still a really significant proportion below that 65-year-old cutoff. It looks like about half or even more than half are below that 65-year-old cutoff. And we're seeing all of these employers doing kind of this like smoke and mirrors thing where they have too few protections in the workplace to protect workers from COVID exposure. But then they say, don't worry, we're going to pull workers in these vulnerable categories away from these high-risk assignments. We're going to pull workers with comorbidities, we're going to pull pregnant workers, we're going to pull workers over 65 away from direct patient care assignments, away from public-facing assignments, and we'll put them in safer assignments. And the employers say, this is how we'll do, this sounds great. But what I think this data really underlines is that everyone is at risk for a severe COVID infection if they are exposed. And then employers really need to protect all workers, not just those in these specific categories. We've learned in the last few months that this virus attacks not just the lungs, but multiple organ systems. And we continue to see new information emerging about how severely this virus can impact people. And on top of that, we know that there is this complicated immune response to the virus that we don't fully understand yet, but that appears to be implicated in some of the ways that this virus shows up for patients. One of the places that is still a really big question is what are the long-term effects of a SARS-CoV-2 infection? We don't have full information, right? It's only been about 160 days, but we have been seeing reports of lasting impacts on people who've recovered from the SARS-2 infection, even when they have mild infections, right? We're seeing some of the reports that are here on the slide, such as the potential for long-term neurological impacts, even with mild or asymptomatic infections. So it's not just a concern about morbidity and mortality within the period of the infection, but it's also thinking about what are the long-term impacts of having had this virus. So one of the other places that we've really learned a lot in the past few weeks is around children, right? So early on in this pandemic, a lot of people thought that kids were not susceptible to this virus or they were not as severely impacted. But we've seen these recent reports of clusters of this new syndrome among children. It's a very severe syndrome. Several children have died. We don't know exactly what causes it yet, but it looks like it's temporally related to COVID. And this discovery just happened in the past few weeks. And I think really, for me, underlined very clearly how little we still actually know about this virus, right? This is a big impact of this virus, and we are just now learning about it. And so I think it is clarifying that, we really don't know everything there is to know about this virus. Okay, so when we're talking about reopening, the other big area that we need to look at, what we learned, is around transmission. So SARS-CoV-2 is highly transmissible between people. I think that's pretty well established at this point. among everyone. And I want to look at this one case cluster because I think it underlines some important things that we've learned about transmission. So this is from a church in Canada where people gathered in early March before a lot of the stay-at-home orders had been issued. They gathered for a birthday party for a member of their community. They observed the 2-meter or 6-foot distancing during the entire event. They observed strict hand hygiene. They wore gloves when they prepared food. They followed all of the rules, so to speak. And still, more than half of them ended up infected with SARS-2, and a few of them have died because of their infections. And this case cluster cannot be explained by droplet and contact transmission only, right? Airborne transmission of this virus is almost certainly happening. And there have been several other reports of similar case clusters at churches, at family reunions, at other kinds of events where people are in close contact with each other or are spending time in the same space with other people that underline how rapidly this virus spreads and how easily it spreads between people, even when there's not this this close contact, right? This 6-foot distance. So there's a couple of other things that I want to point out for you all that we've learned about transmission, because I think they're important for thinking about, like, what does reopening look like and how do we understand reopening more safely. So one thing that we've learned is that patients with a SARS-CoV-2 infection emit a super high viral load. There's been a lot of studies that found active viral replication in the respiratory tract. And when patients sneeze, like you can see in this photo, right, they create a huge amount of droplets or particles of a wide range of sizes that can travel very far distances because they're emitted with force out of the person's body. And that's true for coughs as well. And then we're thinking about talking or singing and even breathing. People still emit a significant amount of respiratory particles that can contain the virus, right, because of where this virus replicates in the respiratory tract. Other things that we've learned, the virus can survive in the environment up to 14 days, depending on environmental conditions. And on certain kinds of surfaces, it can even be up to 7 days. And that's I think an important thing to think about in the context of reopening. This virus can survive up to 16 hours in particles suspended in the air under laboratory conditions. There's been multiple studies looking at the environmental contamination in healthcare settings from both very, very sick patients and also from patients with mild symptoms who were isolated in hospital rooms very early on. And what these studies have all mostly reported is that the virus is found pretty much on every surface, near the patient, far away from the patient, outside the patient's room, in workstations only entered by healthcare workers. The virus has been found in air samples, again, close to the patient, far from the patient. The virus goes everywhere, right? There's this really high viral load. People emit a lot of virus. And that has obviously very concerning implications for nurses and other healthcare workers. But we also can think about this information in the context of reopening, say, a school, or in the context of reopening an office or a restaurant or the DMV. Thinking about this high viral load that's possible just from one person who has an infection. And then the last piece of information that I think we should cover when we're talking about transmission and what we've learned is that there is more and more evidence for fecal transmission. Now, this is something that has been considered since the very beginning of this pandemic, but there's this recent article that was published that actually tested for the infectivity of viral particles isolated from a patient's feces and found that there is infectious virus that can be shed by patients in their feces. And so in the context of reopening, let's think about a public restroom at the mall or even at a school. Every time you flush a toilet, it aerosolizes some of the liquid from the toilet bowl, and that liquid can contain fecal matter, right? That virus, potentially, those droplets containing the virus, every time you flush the toilet, can get kicked into the air and can hang out there for potentially hours for people to breathe as they come in and out of the shared bathrooms, public bathrooms, for the next few hours. So I think to sort of sum up this first part, this review of what we've learned about this virus, we've learned a lot about this virus, but we still don't know everything yet. What we've learned is very scary, and we still don't know what we have left to learn. And so at this moment, we can't abandon the precautionary principle, right? This idea that we should not wait until there's evidence of harm to take action to protect people's health. This idea that we should act out of an abundance of caution, that we don't wait for proof to protect people's health. I think this is a principle that NNU and that MNA have really adhered to, that nurses, as part of your practice, really deeply understand and practice every day, every shift, and that our public health leaders really should be thinking about the application of the precautionary principle in this context of this novel pathogen, right, where there's still so much we don't know about it. It's really important that we continue to stick with it on this idea. Okay, so we're going to shift gears and talk more about reopening. And the way we're going to do that is, so the White House and the CDC have put together these guidelines on opening up America again. And they've proposed these gating criteria that are supposed to be part of how people know it's safe, how states and counties know it's safe to reopen. And I want to take a look at the gating criteria that they've used, because a lot of states have ended up using them in their reopening plans. The VA uses them in their reopening plans. And in addition to these gating criteria, there are also other considerations that are important, like healthcare capacity, PPE testing capacity. But just for the context of this conversation, we're going to look at these three gating criteria together to sort of shape this next part. So the first gating criteria is looking at looking for a downward trajectory in the surveillance of symptoms that match COVID-19 or that are related to COVID-19. We're not going to dive into this first criteria in detail just because of time, but we are going to look at the second and the third criteria in more detail. So the second criteria, you can see the box, the middle box on the slide, is looking for a downward trajectory of documented COVID cases over a 14-day period. And then the third criteria is looking for hospitals treating all patients without crisis care and having a robust testing program in place for at-risk healthcare workers, including antibody testing. Okay, so we're going to take a look at this middle criteria first. Do we see a decrease in cases over the 14 days before these states reopened? So these are charts from the New York Times. And I selected these three states because they did slightly different things in terms of how they made the decisions about reopening. So let's look at New York. So the bars on each day are the new cases reported for that day, and then the solid red line is the 7-day rolling average, because there can be different factors for why each day may have different new cases. The 7-day rolling average gives us a better sense over time of what the actual trajectory of cases is. So let's look at New York. They saw a pretty rapid increase in their cases in early April, and then they waited for a solid, consistent decrease in cases for multiple weeks before they moved to reopening. In contrast, we can look at Minnesota, where there was also a rapid increase in cases a little bit later than in New York, right in mid-April. Reopening happened long before there was a decrease in cases. In fact, there were still significant increase in cases when the decision to reopen happened. But now we're seeing a slight decrease in cases. And then in California, just to have another state here that sometimes folks talk about in terms of policy decisions and understanding policy, there's been a very consistent and very steady increase in cases this entire time. And even though there's been this consistent increase in cases, Governor Newsom in California has inched closer and closer to fully reopening the state, and has actually said that even though cases are still climbing, he is not going to walk back on reopening. So just to summarize overall, the vast majority of states, New York being the big exception, did not wait for a sustained 14-day decrease in cases before they reopened. And there's another wrinkle here. Several states have recently admitted to manipulating their data to make the metrics look better so they can reopen sooner. And I think that this point, more than any other, really clarifies where the loyalties of our policymakers are, which is to say with the economy, with employers, with capital, rather than with workers, with our communities, or with public health. For example, DC was using a community spread metric that ignored nursing homes, correctional facilities, and other institutions to make their numbers look better. Georgia was caught mixing their antibody and PCR tests to inflate the total number so that they could reopen sooner. And since that news broke about Georgia, it's come out that at least 6 other states have also been mixing these data inappropriately, including Pennsylvania, Texas, Vermont, and Maine. And it has come out that the CDC has been doing this too. There's an excerpt from this article that I think hopefully explains why this is concerning and what it does. Because antibody tests are meant to be used on the general population, not just symptomatic people, they will in most cases have a lower percentage positive rate than viral tests. So blending viral and antibody tests will drive down your positive rate in a very dramatic way. And there's, of course, other issues with the state-based data. For example, many states don't publicly report hospitalization data. So we won't be able to see that start of that uptick of hospitalizations that would signal needing to re-close again. States are all over the map on how they're tracking and recording cases, on how they classify deaths, all of which are very important metrics for understanding the spread of this virus and what safe or reopening looks like. So most states are not meeting this middle criteria and did not meet this middle criteria before they proceeded with reopening. Let's look at this third box here on the slide. Hospitals treating all patients without crisis care. Is this happening yet? My sense of it is no. We know that hospitals across the United States are not yet treating all patients without crisis care. And what we're actually seeing is that hospitals are doing the opposite. Many hospitals are actually working actively to incorporate crisis standards as a new ongoing normal. So let's look at this in a little bit more detail in the context of PPE, right? PPE has been one of the biggest issues in this pandemic. Hospitals have implemented many of these crisis strategies to deal with the PPE shortage. And we can see some of these crisis strategies reflected in the CDC's guidelines, right? We can talk about using expired N95 respirators, extended use, wearing the same N95 respirator for multiple hours, reusing the same N95 respirator for a whole shift or for multiple shifts, prioritizing or rationing N95s for aerosol generating procedures only. And I would also point out in this conversation that we still have not been able to get clarity on what the actual PPE supply chain looks like, right? And what hospital stock looks like. We have been asking and working and trying to dig to find clear information on what this supply actually looks like, right? Because the hospitals are all saying that they have a shortage and that the stockpiles, the state stockpiles and the national stockpile are all gone. but that doesn't necessarily mesh with what we hear from nurses. But that's sort of a side point here. When we're talking about these crisis strategies, right, are reuse and extended use of N95s becoming common practice? There is no centralized reporting or tracking of these practices, but anecdotally, the answer to this question is yes. We are seeing nurses report across the United States that reuse is an ongoing, consistent practice, that extended use is becoming common practice. And we're seeing employers framing this maintenance of crisis standards, like on this memo on resuming elective procedures from one employer, this last line, they're framing it, we will continue proactive conservation of PPE. So even though this employer has a stock and supply of N95s right now, they are continuing rationing, reusing, extended use, decontamination in the interim or potentially for the long run to save money. And this proactive conservation is how they're talking about it. One of the other big crisis strategies, crisis standards that employers have implemented is the decontamination of N95s. I'm not sure the extent to which Minnesota nurses have encountered decontamination policies at this point, but if you haven't yet, it may very well be coming very, very soon. We're seeing employers across the country, from Massachusetts to California to Texas to Florida, very quickly rush to embrace the ability to reuse an N95, honestly, an indefinite number of times. And these are very dangerous practices, right? They have not been studied, they've not been validated, and many of them destroy or degrade the N95 so that it doesn't provide protection. So Battelle is the biggest company that has been rolled out. If you look at the map of the states where Battelle is up and running, you can see there's vast coverage, and this has actually been all paid for by the federal government. But we're seeing some employers, for example, UCSF, reshaping their policies around decontamination being this long-run strategy. So UCSF has N95s in stock. They have a supply of N95s. But when they're creating these procedures for reopening elective areas, they're directing staff to put on a reusable N95. There is no such thing as a reusable N95. And yet we see UCSF redefining what an N95 is and how it can be used. This is, I think, a very clear example of how employers are implementing these crisis standards as an ongoing long-term practice. So, in no way is the first half of this third box being met. And we just talked about PPE. We didn't talk about staffing, and scheduling issues, and scope of practice manipulations that employers implemented during the surge of COVID patients and are continuing to try to push. I know that NNU's nursing practice department has a great CE class that is looking at these issues in depth. And if you haven't sat in on that class, it's really great. It's on our website under the CE class tab. That class explores these other issues around the maintenance of these crisis standards as ongoing practice when we're thinking about nurses' scope of practice and competencies and staffing levels. So let's take a look at this last part of this third criteria, the meeting robust testing for healthcare workers. So we know that robust testing does not exist for healthcare workers. NNU's health and safety survey results from 23,000 nurses across the country reported that 84% of nurses have not been tested for COVID-19. And what we're seeing is that in many ways, employers are making this a, if you don't test, it's not a problem kind of situation by ignoring testing. And not only is there not robust testing, but employers are actively trying to abdicate as much responsibility as they can for protecting nurses and for responding to exposures due to the PPE issues that we just talked about briefly. And we're seeing employers using this community transmission defense to pretend like workplace exposures are not happening. And we've seen multiple times throughout this pandemic that the CDC guidance has changed to sort of match what employers are doing on the ground. And I think that this CDC guidance really reflects what a lot of employers are doing, and this is from a CDC COCO call where they explain some of their policy and they present some of this information to practitioners across the country, where they talk about this risk assessment of potentially exposed healthcare personnel having become impractical for many employers, right? And I would also point out, since we're talking about reopening, that this is not just a problem for healthcare workers. This is also happening in other industries. And you can see this headline from Azar, the Secretary of HHS, blamed the outbreaks happening in meatpacking facilities on the workers' home and social conditions, right? This community transmission defense, trying to advocate responsibility for what's happening in the workplace. And I want to talk for a second about this other kind of testing, antibody testing, that's called out specifically in that third gating criteria. This antibody testing is really central to a lot of reopening plans. You can see the quote from Governor Cuomo of New York. He and many other governors and policymakers have talked about antibody testing as being this like magic bullet of sorts that will allow them to cave to pressure from business owners while covering up the fact that they've put in place too few worker protections. So in addition to that, Robert Redfield, who's the CDC director, has also started talking about antibody testing as preparation for the second surge in patients. But all of these governors' plans around antibody testing rely on this bad assumption that a positive antibody test means someone is immune. This is not true. We don't have the information we need to be able to make that assumption, and there are too many problems with the currently available tests to be able to rely on them for these kinds of policies that the governors are talking about. We have too many unanswered questions about this virus and what immunity looks like. We don't know anything about long-term immunity, right? It's only been about 160 days. We don't know what immunity or what antibody levels will even look like a year from now. And that's an important question to ask when we're thinking about reopening. What kinds of antibodies provide protection? Do they provide protection? What kind of protection do they provide? Are there different strains? How do antibodies provide more or less protection to different strains? We don't have any information on those kinds of questions yet. We do know that antibodies to other coronaviruses, right? This big family of viruses, SARS-CoV-2 is one of the viruses. One is a coronavirus. SARS and MERS, and there are some seasonal colds that are caused by coronaviruses. Antibodies to those other coronaviruses can be very short-lived or weak. Like if we're thinking about MERS and SARS, antibody protection from future reinfection is very weak and not very long-lived for these other viruses that are in the same family. And another really big issue when we're thinking about antibody testing is that many of the antibody tests being sold right now are unreliable. It took multiple months and a lot of public pressure for the FDA to regulate antibody tests at all. And I'll also say that even the CDC and the World Health Organization, neither of which has taken any real leadership in this pandemic, but they've both recently recognized the fact that antibody tests may or may not be accurate. There's an issue brief on NNU's website if you want to dig into more details about antibody testing and some of these issues surrounding antibody testing and the science around antibody testing. There's one more factor here that I want to talk about before we move on from antibody tests, and it relates to specifically what healthcare workers might experience from these policies that governors and employers are talking about and implementing that are really focused on rolling out antibody testing. And this is a quote from a University of Southern California researcher about what he thinks will be, some of the ways that antibody tests may be used. So the quote says, think about healthcare workers on the front lines. Some might have antibodies, and if they know that they have those antibodies, they'll feel less anxious. I'm all for testing healthcare workers if it can reduce their anxiety and the anxiety of their families. If there's a shortage of personal protective equipment and there's only one mask, who do you want to wear that mask? The person with antibodies or a person without antibodies? Ideally, you want everyone to wear a mask, but if there is a shortage, this also might help prioritize limited resources to certain individuals. Okay, so instead of focusing on PPE and workplace protections, employers are gravitating to antibody testing as the thing that needs to be in place for the next surge. And we can see what that impact will be displayed in this quote, right? So I think, just to summarize, by their own criteria, most states were not ready to reopen when they reopened, and many states are still not ready to reopen. And we know what the impacts will be of this unsafe or this early reopening. It will cost many lives. There's a big modeling study that was published a few weeks ago that looked at the available data and said, based on their model, if social distancing and other policies had been implemented 1 week earlier, more than half of the reported infections and reported deaths would have been avoided. And they also looked forward, thinking about the states that are reopening, and said a delay of just 1 week in reinstituting these interventions, the stay-at-home orders, the physical distancing orders, the closure orders, delay of 1 week will result in significant morbidity and mortality. And we're already seeing multiple states reporting big surges in cases after reopening: North Carolina, Texas, Georgia, Florida, Alabama, and others. And there's been very, very few states even discussing reclosing, right? Oregon is one of the only states. I think Miami is talking about reclosing or slowing down reopening, but largely reclosing has not been part of this discussion, and it really, really needs to be part of the discussion. And I think we can learn from history here. The 1918 influenza pandemic was in many respects very similar to what we're seeing with COVID-19 right now. There's some really great data on deaths from the 1918 influenza pandemic from Denver that are in this graph on the slide. And you can see they saw a rapid increase in cases as the pandemic started. They implemented stay-at-home orders, and they closed businesses and they closed schools. And you can see the decrease in cases. And then under pressure from business owners, they removed those protections. They removed the business closures. They removed all of those kinds of stay-at-home orders. And then there was this rapid second surge where a lot of people died. And that didn't just happen in Denver. It happened in other places. Denver just has some of the best data historically to report. So there's one more thing I think we should consider when we're thinking about the impact of reopening is the disparities in who is currently most impacted by COVID-19. So we've seen that the infection rates and mortality rates are much higher in Black and Latinx populations compared to white populations. And that's held true in multiple states that have reported the data. Not all states are reporting the data. We don't have great data on cases in Native American communities, but we do know that there's rapid transmission in many Native American communities, and that they are being ignored, but they're not getting what they need to respond to the outbreaks in their communities. And when we're talking about reopening, we know who will be most impacted, right? Thinking about the service occupations, those folks who have more exposure to the public, occupations like protective service, food preparation, food service, building and grounds cleaning and maintenance, personal care and service occupations, right? These are the gyms, these are the spas, these are the stores. This work can't be done at home. There's a significantly higher proportion of Black and Latinx workers in these service occupations compared to white workers. And this is according to the Bureau of Labor Statistics data. And so we'll continue to see these disparities in who is most impacted by this virus as states rush to reopen. Okay, so it is too early to reopen. States really need to be moving towards reclosing. until they have some of these things in place. This is a distillation of NNU's position statement on what it means to safely publicly reopen. We know that there are things that need to be in place for reopening to happen safely, right? Basic human needs need to be met. We need unemployment benefits, paid sick time and family leave, food security, housing, healthcare, and social supports. Public health and safety is a really important aspect of safely reopening. One of the things that we've really learned in this pandemic is how interconnected our health is with everyone else, right? We know, you know, as nurses, that the hospitals have a direct connection. What happens in the hospital is a direct connection to our community's health. But we're learning anew what happens in the meat packing plants has a direct connection to our community's health. What happens in our schools, what happens in our malls even has a direct impact. And so thinking about all workers need protection, all workers, we need an enforceable OSHA standard would be an important step towards this, as well as the domestic manufacturing of PPE that should have started in February when it became clear that there was going to be a pandemic and that there was going to not be enough PPE manufactured. And of course, safety in our healthcare facilities, in our nursing facilities, in our jails, and other institutions. And if we reopen, if we don't do the physical distancing, if we don't have the stay-at-home orders, then we have to have this public health infrastructure in place to prevent transmission. And that public health infrastructure must include widespread testing. And we still don't have this anywhere in the US. Only a fraction, less than 10% of the US population has even been tested once at this point. We need contact tracing and case isolation. And then, of course, everyone on this call is well familiar with the need for healthcare capacity and preparedness in the context of this pandemic. If reopening is going to happen, the healthcare facilities must be prepared for a possible surge. The importance of healthcare worker safety cannot be overstated. PPE, staffing, and other workplace protections. Surge capacity is very important. We're seeing governors closing some of the surge capacity that they built early on in the pandemic while reopening prematurely, which is just a very irresponsible move. And then, of course, access to healthcare. I am sure everyone on this call deeply understands why access to healthcare, free healthcare without barriers for everyone is such an important part of what we need in this country to combat this pandemic. If people can't get healthcare when they get COVID, then they're going to stay at home, they're going to stay in the community, they're going to continue to go to work, and we're going to continue to see more transmission. Okay, so I want to talk briefly about hospital safety during COVID-19. For hospitals to reopen, there are clear things that they need to have in place. This is also obviously a piece of public reopening, and we know that nurses' safety is so deeply important to everyone's safety. What you see on the slide is a distillation of some of the absolutely major points that are in both our model standards for a COVID-19 surge, thinking about what needs to happen within the healthcare, the hospital, for preparation for safely dealing with a surge in COVID patients. And these are the principles that underlie what hospitals need to have in place to safely reopen procedural and outpatient areas. These are kind of basic principles. And this was really these principles are built on our research that NNU staff did early on around what other countries have been able to do to prevent transmission within hospitals and to control the spread of this virus, and as well as some other research. So these basic principles, all patients need to be considered PUIs until they are confidently ruled in or ruled out as COVID patients. And that ruling in and ruling out needs to use not just tests, but also thinking about the patient's clinical symptoms and any kind of epidemiological factors, any kind of exposure that they've had to other folks, or any kind of potential for exposure to COVID. The second is this three-zone model, the need for separate designated areas of the facility that are rigidly and carefully maintained to prevent any kind of cross-contamination. This is one of the big pieces that hospitals in other countries effectively implemented to prevent transmission within the facilities. The third principle is PPE. We nurses still need optimal PPE, and we absolutely have to have a full supply assured full supply, and nurses have to have access to PPE. And then the fourth is sort of this other workplace protections, including negative pressure rooms, converting entire floors to negative pressure, having active exposure surveillance, making sure that any exposures are tracked and followed, that nurses who are exposed are put on a precautionary leave, universal masking, frequent environmental cleaning. There are a lot more details in these two documents that are on our NNU website. And nurses, I'll also just say that nurses have already seen the impacts when hospitals don't have these programs in place, right? Especially as they're reopening. We've heard so many, just too many reports of exposures in multiple hospitals where patients are admitted, but they're not screened for COVID. They end up positive, multiple staff are infected, and unknown numbers are exposed. It's happened multiple times and shouldn't be happening. So just to speak briefly about PPE, everything that we're seeing reported about this virus continues to underline NNU's calls for the highest level of protection. Everyone here is well familiar with PPE needs and related issues. And I think, NNU's calls for increased PPE production and regulation of the distribution of PPE to make sure that nurses actually get it are a very important part of what reopening more safely would look like. And just a few final thoughts to really summarize what we've been talking about. If you all remember Wuhan, China, right, this is where this all started. This is where the first cases of COVID-19 were identified. They had gotten their cases down to zero. They had no new cases reported for multiple weeks before they reopened, before they lifted their lockdown. They started to see a few reports of new cases in early May, and they immediately responded with a program to test every resident of their population of 11 million. And they were able to do that over a period of 2 weeks. They were able to test 11 million people and to process those tests. And they also have more case isolation and contact tracing and other public health controls in place than we have. South Korea had also gotten their cases down close to zero before reopening. You can see in this report, they saw a report of 79 new cases in 1 day, and that was the biggest daily rise. And as a result of that daily rise, they closed back down. They closed their schools. They reinstituted a lot of their stay-at-home measures. In contrast, the United States is seeing about 20 to 25,000 new cases reported each day. And between a few hundred and 1,000 new deaths reported each day. And the U.S. has already reopened, and there's no signs of reclosing quickly. And, I think everyone's sort of been asking this question, like, are we there yet? Can we reopen yet? Everyone is totally done with staying at home. But the answer is no, we're not there yet. We don't have in place the things that we need to reopen safely. And this virus is still very much a threat. It's not over. We're not done with it. And the final thought I'll finish up with before we move to Q&A is that Bonnie Castillo, the executive director for NNU, has been talking about this time, right, this crisis as being an opportunity to change the ways that we do things. We can't return to our pre-COVID normal. We don't want to return to our pre-COVID normal. But we can re-envision how our society is shaped. And I think that this question of reopening, of when to reopen and when to reclose, is one of the most important and immediate ways to make this idea real. To make real this shift in priorities. What is the priority in this moment? Is it to get the economy back up and running and to get business owners making profits as quickly as possible? Or is the priority the health of our communities, and in particular the health of workers and those who we know are most impacted by this virus? And I think that this is, we've covered a lot of information today, and there are a lot of questions I see. Okay. Let's take a look. We have a few minutes for questions now. So there's a question, would we benefit from a balanced approach in reporting deaths, e.g. deaths related to other illnesses, not just COVID? Yes, there are many issues with the ways that Mortality rates are reported and recorded, and many states are not following even the CDC's bare minimum guidance on how to report that. That is one of the places that we don't have the data that we need, and that could be improved. There's a question, what is the number of frontline workers with COVID and deaths? That is a very, very important question. And unfortunately, we have not seen the data gathering that we should. And NU has been calling for employers to track that information, as well as for our public health agencies to track that information. But they haven't been. The CDC did, because of pressure from unions, just recently add the healthcare worker infections and death data that they have to their website. But they only get that data for about 20% of cases, right? So we don't actually know for the vast majority of cases whether they were a healthcare worker or not. And there is not any kind of mandatory reporting for other kinds of essential workers or other kinds of frontline workers. Okay. There's a question about the reuse of masks. Does the reuse of masks decrease the effect or affect the efficacy of the mask? So the answer is yes. Reuse of an N95 respirator will degrade the N95, and it happens through a couple of mechanisms. One of those mechanisms is that just the integrity of the face piece and the stretchiness or the force of the straps will get degraded. The more times you put it on and take it off, the faster it wears out. The other way that the efficacy of the mask can be degraded through reuse is sometimes we call it loading. The N95s filter out particles that are in the air, and that filter can get full. So I don't know, many of you may have had this experience where you're wearing an N95 for a period of time and you start to notice that it's become harder to breathe through the N95. That's called, that means that N95 is essentially full. The filter has become full and needs to be discarded, and you need a new one. So that's another way that reuse can decrease the efficacy of the mask. Okay, I'm looking through these questions. Jerry, I want to check in really quickly and do a time check. What is our end time? Do we need to be done right at 11, or can we go over a few minutes?
I think we can certainly go over. If folks need to jump off, they can, but I do see we have a long list of questions, so please do keep going if you have time.
Okay, great. Okay, so let's see. So there's a question about transmission. Do you think it's even possible to stop transmission given most hospitals would test positive throughout the environment? So I think that this is one of the places where that 3-zone model really would be impactful. The ways that 3-zone model works is that the hospitals set up specific and clearly delineated spaces. And each patient who comes in is treated as a PUI. They go to the PUI, or the potentially infectious zone, until they are ruled out or ruled in. And then they move to either the positive zone or to the clean zone. And that there's frequent cleaning, and there's staffing, and there's PPE to make sure that those zones stay their respective zones, and that COVID does not, or the SARS-2 virus does not end up throughout the environment. So yes, I think it is possible to stop transmission within a hospital and to stop transmission within the facilities. The hospitals just have to step up and put in place the measures that they should have had in place in February. There's a question, how did they obtain 11 million test kits? I think that's a question about Wuhan. They were able to manufacture the test kits that they needed. And they had what they needed. Well, I could also say one of the other strategies that Wuhan implemented was called batch testing, which allowed them to accelerate the timeline. Batch testing is when you test samples from a group of people, and if it is negative, then all of those people are negative. If that batch sample from that group of people is positive, then you test each individual samples. How can these hospital safety standards be implemented in rural small hospitals? Should all high index of suspicion patients be transferred? So rural hospitals should be able to implement many of these measures in much the same ways as large hospitals or as urban hospitals. Certainly there are some rural hospitals that might consider transferring patients who are pretty clearly COVID patients from either their clinical picture or from their contacts, right? Their contact history, their epidemiological risk factors. But rural hospitals should be able to put in place many of the same measures, the 3-zone model, the environmental cleaning, and absolutely should have the same standards for PPE as other hospitals. Has COVID become the #1 cause of death in the USA? I don't have the data for today, but a few weeks ago, yes, COVID was causing more deaths each day than other causes. Instead of N95s, what is your thought on 3M's HAP face masks 6100? We are told to just wash them down after our shift and that they will last indefinitely. Okay, so it sounds like these are likely the elastomeric respirators that have the canisters that are made to be reusable. So those, well, #1, those do not last indefinitely, but they do last for a long time, and they are designed to be cleaned and decontaminated between reuses. The hospital should have a plan in place for how that cleaning is going to happen. It's not just a wipe down. The wipe down might happen during your shift between uses, like you put it on, take it off. You might wipe it down when you take it off. But at the end of the shift, the respirator should be washed. It should be taken apart and washed. And that's part of OSHA's mandatory respiratory protection program standard. And the hospital needs to have a plan in place for how that's going to happen. And that's important because there's, all the nooks and crannies on that half face piece elastomeric respirator that do need to get washed with soap and water and with some kind of decontamination chemical. The hospital needs to have a clear plan in place for how you will be trained on recognizing that the elastomeric is degrading. The straps are worn out, a piece is broken, whatever that degradation looks like, the hospital needs to train you on how to recognize it and should have a plan to replace it when that happens. I will also point out that the filter cartridges, right? So these are elastomeric respirators that have the canisters. Either there's 2 canisters or there can be 1 canister in different places. And the filter you put inside that canister, and that filter does need to be replaced periodically. Different manufacturers have different recommendations for how often those get replaced. And the employer needs to replace them at least that often, as well as if they ever get splashed or wet or soiled in some other way, they need to be replaced as well. Okay. Okay, so there's a question about healthcare worker infections. One Minnesota hospital CNO has told us that the conversion rate for healthcare workers at her hospital is 0.68%, based on healthcare workers with medium and high-risk exposures who have tested positive, and claimed that this is well below the national rate. Do we know what the national rate is? No. To my knowledge, there is no clear publicly reported national conversion rate. That is still an unknown answer or an unknown piece of information. I would encourage you all, if you can, to go back to that individual and ask them for that information. What is the national conversion rate and how did they get that info? Because to my knowledge, that has not been widely published. So there's a question, given the current culture with protests, could this be a possible sampling of natural immunity? So I'm not sure I 100% understand this question, but I think perhaps you're asking, could this be a way to understand who is more likely to get infected? And I think the answer is no, because we don't have information on exposure, right? In any given crowd, we don't know if there is exposure or how it works. I think when we're talking about the protests, there are some things we may be able to learn from people being in crowds, learn about this virus from people being in crowds, but I'm not sure that we can learn about immunity in that way. Okay, I'm gonna do one more pass because I think there's a couple of questions that I haven't answered yet. Given the recent notice for individuals exposed related to protest for free testing, would this premise be similar to frontline workers? So NMU has been advocating that frontline workers, for nurses and for other healthcare workers in particular, to have access to testing for free when they feel that they have been exposed. That is something that's available in some states. It's something that's available in some workplaces. It's something that should be available to all healthcare workers at this point. Okay, so there's a question, is it true that suicides rose during the state's closures, whether it be related to isolation, finances, chemical abuse, misuse? If so, how do we as nurses balance that health crisis and the pandemic crisis? So I also saw these headlines about this study that reported that there was an increase in suicides related to state's closures, but there's been some discussion about the methodology of that study being very, very flawed, to the point that actually there does not appear to be a rise in suicides related to the state's closures. That's not something that was actually reflected in that data set. That study was flawed in the ways that it looked at and analyzed the data. Okay. Looking back through one more pass. So there's a question about stress, I think. Would we benefit from a defense approach, e.g. increasing natural immunity through decreased stress? So I think overall nurses need to be protected at work. Nurses need the PPE that they need, and they need the other workplace protections. Employers are obligated legally and morally to provide those protections. I would say in addition to that, we know that stress has been an issue for many nurses for a long time, right? That predates in many ways the COVID crisis. And that's a lot of that stress is related to many of the pressures at work. A lot of the pressure to speed up, a lot of the short staffing, the push of patients through the facility faster, right? A lot of those kinds of factors. And that is a health hazard in the workplace that we have been advocating for fixes for a long time. And I think COVID, if anything, has really underlined the importance of all of these factors impacting nurses' health and safety, right? Not just PPE, but thinking about staffing and the other ways that work impacts nurses' health, physical and mental and emotional. So, you know, that's not necessarily explicitly around stress and immunity. We do know that stress can impact your immune system, but also in general, that stress is something that employers need to pay attention to for nurses. Okay, so Jerry, I think I've answered all of the questions that I am able to answer. Some of them are sort of duplicate questions that I think I answered with other. Okay, and I see that you answered the one that I didn't have an answer to. So okay.
There was one question that just came in about will the slides or recordings of the webinar be accessible? We usually will record our webinars and put them on our on our YouTube channel. Is that okay with you if we post this after it's recorded?
Let me double check about the recording, but the slides, I have a PDF in my files that I can send you after.
Perfect. So we will send the slides out to everyone that attended by email as soon as we get those from Jane. So I think that's all I see about remaining business. So I do want to encourage everybody to look at the National Nurses United website. It's nationalnursesunitedorg/COVID-19. There's so much information there. So I encourage everyone to go look. Jane, thank you so much for talking to us, for your presentation, for all your tremendous work on this research, everything you're doing for nurses.
Thank you guys for having me. It was great to be with you all. Keep up the good work. I know it's been a long and hard fight, and we are not out of it, but it is an honor to be here with you in this fight, and you know, we will win. Nurses are so powerful when you work together. So thank you all for having me.
All right, thanks everybody, goodbye.